Thank you so much for the invitation. It's been a lot of fun this evening. See a lot of people that I haven't seen in a long, long time. And Jay, I'm gonna come dump some money with you. I have a Mini Cooper that goes fast too. So we can actually put a turbo on it. So we're gonna have fun. All right, so Deval asked me to talk about this. And I'm like, Deval, why am I talking about this and not you? You're the congenital guy. I barely understand this. So I shout out goes to Yazan, is one of our fellows that actually went through the images with me, along with, of course, Dr. Conru, Dr. Srikanth Konero, that has done the images, obtained those images, and of course, Deval. But this is what we're going to talk about, mitral clip. You guys all know about a mitral clip. We create an Alfieri stitch, as you can see here. And percutaneously, without opening the heart, basically, as the heart is beating, we can create that bridge of tissue that will hopefully improve mitral regurgitation. We all have used mitral clips a lot for this. I'm sorry this is not playing, but basically for pathology that's degenerative MR, very localized, it works really, really well. It goes. So, fortunately, this is not playing, but this is how we created a little bridge of tissue there, and essentially with a lot of improvement in MR. Essentially, there are several patients that we should be doing mitral clips. And this is an old case of ours that we kind of learned the hard way. This is a patient that has really, really bad. Here you see that this is not a good clip case. Not a good clip case at all. But how about this one here? So what are we looking at here? We're essentially looking at the top there. This is transesophageal. Up here is the common atria. And this is the common AV valve. This is the remnant of a left ventricle. And this is what they call the systemic ventricle, right, Conero? The systemic ventricle. That is the dominant ventricle that has an RV morphology. So for the uninitiated like me in the audience, what we're dealing here with is this is the normal anatomy. Essentially, this is endocardial Cushing defect where you have no atrial septum and no ventricular septum. So you have this big hole here in between the walls of the heart. You see here that right atrium, right ventricle, normal anatomy, and there's a common atria, a common AV valve, and essentially a big VSD. Those valves are not the valves that we see usually, and they can have, I learned this week, they can have usually 5 leaflets, and some of them have 4, some of them have 3. It depends on the patient's anatomy. This kind of endocardial Cushing defect is also associated with other congenital anomalies. And in our patient that we're going to present, the patient had pulmonary atresia. And we're very fortunate that this patient did not have an extra cardiac shunt, did not have a Fontaine. That's how it allowed us to do this. So what you're looking at here is a 3-dimensional reconstruction beautifully done by Dr. Conero, where we see here the remnant of the interventricular septum. Here is your, what we call the AV valve, which is a mixture of the tricuspid and the mitral valve together. This is the left ventricular remnant, and this is the systemic ventricle. You see clearly here that there is some prolapse of this leaflet. This is called the posterior leaflet. This is the anterior, and here, somewhere here is the aorta. You see here that there is also a medial leaflet there that is kind of trying to come to fruition, but did not. So the patient we did was, and Jay said he did 3 cases, right? This is our second case. So 51-year-old woman with, like I said, atrioventricular septal defect, pulmonary atresia, common atria, and severe regurgitant AV valve. Patient had recurrent heart failure, oxygen dependent, and Dr. Cooley and Watterson developed this surgery that I'm going to show you right here, where basically they're giving, because of the pulmonary atresia, the patient needed to have the lungs somehow perfused, and you can actually get a shunt right here to the right PA, and that's what was done when the patient was born. And Dr. Parekh opened up that shunt again in 2020. So you see here that this is a very sick patient. This patient did not have a lot of options. This patient was not a surgical patient. This patient, even Liao would not take the patient to the OR. So this is a conference that is fantastic because it shows that Houston is very, very potent whenever we are together. And as I get older, I understand my mistakes and I understand where I should have collaborated more with people. So I'm in this kick and this, like my kids say, this vibe of trying to get everybody together. And Deval is our natural photographer here. So you see here that we had this little meeting at the Westin, and shout out to Dr. Simpson as well, that is here, big part of the group. We miss him dearly. And Dr. Diaz too, that at this day was probably working while we were having fun. And we have a transplant here, literally. Dr. Nair, who's not an interventionist, but wants to be one. I hope he gets there soon. So this is the group that did this case, us four together. And this is kind of, I was thinking preparing this talk, how am I gonna tell people? This patient has dextrocardia, right? And one of my fears, one of those fears when you wake up in the morning, like, oh my God, I'm in England, I have to do a stick shift in the wrong side of the road. This is exactly how I felt that morning when I woke up to do this case. It's like, okay, I drive stick shift, but with my right hand, not with my left hand. And I thought, we're just gonna crash. This is not gonna go well. And this is like, why is this pointing this way and not this way? Oh, dumb, this is dextrocardia. So that's kind of the spirit. And once you have four people in the room that have egos that are quite small, even if you know what I mean, four interventional cardiologists trying to decide what to do, because Srikanth is also an interventional cardiologist and an imager, and Deval has done congenital and adult. Leo is a heart failure interventionalist and EP. I'm the only guy that's structural and interventional. And I'm looking at all those guys, everybody's yelling, saying, you do this, do that. And I'm like, okay, guys, shut the hell up. Let's just, one at a time, please. So literally, we kind of went through this, and Srikanth explained to me today, or yesterday, about the NPR. He's like, look, you need to put this, green thing here, right here. And I kind of understand now, which is great, because basically we need to be at the right point of coaptation to really put the clip here. So basically he would tell us, look, this is where he goes, and once we put the NPR here, those two images here tell us, this will be the biochemistry view, and this would be the equivalent of the LVOT view. Essentially, one is lateral and medial, the other one is anterior and posterior. And so then what we do is we use the clip to find. It's not like he's gonna find us. We're gonna find him, meaning we're gonna make sure that in the LVOT view, you see the two arms of the clip, and that in the biochemistry view, you're gonna see the clip in foreshortened. So basically, this is lateral, this is medial, and you see here beautifully that the leaflets, and Dr. Danny Herman does a lot of this, and we love when we see this going up and down, because we know we got leaflets in between. So between the moment that we started this case to this moment, it was about what, an hour and change, and we're very happy that we got at least one down. After we put one clip, it makes it a little bit easier, because we do have the what I understand more, which is fluoroscopy, and is basically matching. You match one, and you match the other one in terms of the arms, and this is what it looks like at the end. You see here that this is the LV, or the remnant LV, systemic, and those are the two clips. Of course, this is not a case where we show up and we say, we're full of testosterone, we did great. This is a case to really improve the patient's life. And essentially, you do still have quite a significant amount of MR. We knew that going into this case. But above all, I think that this is a great example of what we can do with collaboration, that if we are organized, if we harvest the best of each of us in this room and in the cath lab, we can certainly make this a lot better for our patients. Thank you very much.